Good afternoon, everyone. My name is Jamie, and on behalf of Lung Foundation Australia, I would like to welcome you to today's webinar. Today, our speakers will provide us with an insight into the University of Tasmania's research on the epidemiology of IPF, and is brought to you in collaboration with the Centre of Research Excellence in Pulmonary Fibrosis. Before we begin, I would like to acknowledge the traditional owners of country throughout Australia and their continuing connection to land, sea and community. I pay my respects to them and their cultures and to elders past, present and emerging. So thank you to everyone who's joining us today. We're very lucky to have three wonderful guest speakers joining us, and before I introduce them, I will just run through some quick housekeeping points. So there will be a Q&A session towards the end of the webinar. So if you're joining us live, please submit your questions through the Q&A box at the bottom of your screen, and you can send them through at any time throughout the presentations. Just a reminder for those who have registered and are joining us live, you will receive the recording to today's webinar when it becomes available. We do also encourage you to please take part in any of the post-webinar surveys. You'll see a short one pop up as you exit the webinar today or on your screen if you're listening to the recording. So please participate in this if you have time. They're designed so that we can get your feedback and continue to bring you topics in education that's most relevant to you. So I'd now like to introduce our speakers for today. We're very pleased to have Professor Hayden Walters joining us to present first up. Professor Walters is a Professor of Medicine and Clinical Chief of Medicine at the Royal Hobart Hospital. We're also very pleased to have physicians Dr. Ingrid Cox and Dr. Chang Zhen joining us as well. So when you're ready, Hayden, I'll hand over to you firstly.
Thank you very much. And thank you for all the organisation and all work you've put in, Jamie, much appreciated. I should perhaps say that I'm now semi-retired from these exalted titles, and the work has become something of an obsessive hobby, I suppose you could say. The bulk of this webinar will be given by our two PhD students that I supervise jointly with Andrew Palmer, who's Professor of Health Economics at the university. I wanted, though, before I properly introduce Ingrid and Chang, to make 3 points about IPF, just as really a background platform on which our PhD students' work is based and therefore relevant to their talk. Idiopathic pulmonary fibrosis is what we've been investigating. Now, the word idiopathic means we have little understanding of. Now, that actually is no longer true, I'm glad to say. We know a lot about this form of progressive lung fibrosis, and we really need to change the name. I have been in research for quite a long time, and for my first 20 years, I focused on asthma, and then in the recent 20 years on chronic obstructive pulmonary disease and IPF. Now, COPD is a complex disease, but essentially it is fibrosis and destruction of the small air tubes within the lung, whereas pulmonary fibrosis affects the air sacs in the spongy part of the lung. But in many ways, the pathology we now realize is much the same. We used to think it was all about inflammation, but we now realize that the core pathology is an activation of the stem cells in the inner lining skin of the airways and of these air sacs. They become activated, they produce substances called growth factors, and these growth factors lead to stimulation of fibroblasts and the laying down of scar tissue. So the pathology is much the same, and the risk factors to some extent of the two illnesses are the same. Smoking plays a part as a risk factor, and so does general pollution in the atmosphere, particularly particulates in the atmosphere. But for IPF, pulmonary fibrosis, genetics and family history is much more important. That is by far the most important aspect of IPF is a family history. Now, some of those issues are dealt with in two recent papers that I've written with a close colleague of mine called Michael Abramson, and they'll be available, I think, in the background information that Jamie will provide. The final point I want to make is that because we now understand this illness much, much better than we used to, it means that we can produce drugs to affect this basic core pathology. At least 2 antifibrotic drugs are now available. And a part of the talk will, the talks, particularly Chang's talk, will refer to what we now know about the effectiveness at a public health level of these drugs. So I'll now introduce Ingrid. Ingrid is from the West Indies, from St. Lucia. She graduated very exotically in Cuba, did some pediatrics and infectious disease medicine, then went into public health and worked with the WHO around the Caribbean before coming to Australia in 2016 to do a master's in health economics and health planning in Adelaide, and then came to us in 2018 to start her PhD. So she's almost at the end of that and has done extremely well. Chang is from China, from Anhui, which is Middle Eastern part of China. And he's been training in surgery and anesthetics as a master's in that, and has left that for the moment to do his PhD here. So 2 very well qualified, very experienced PhD students, and it's been a great experience working with them. So I now hand over to them to give the bulk of this talk. Thank you.
Thank you, Hayden, for that lovely introduction. And thank you, Jamie, for accommodating our presentations, which I think will be quite informative to our audience. Okay, so begin. So today, as Jamie and Hayden mentioned, we'll be providing some insights into some of the work that we have been doing over the past few years. So our presentation today will review some of the work being done at Menzies, the Menzies Institute for Medical Research in support of the Lung Foundation and the Center for Research Excellence in Pulmonary Fibrosis. We will look at the health burden and also look at the economic burden or aspects, and then look at some of the work that we're planning to do in the future. So our work is focused on 2 aspects of IPF, the health burden, or as we technically call it, the epidemiology. And this focuses on incidence or new cases, prevalence or living cases, mortality and survival. And secondly, the economic burden or the health economic aspects, which mainly focus on quality of life, costs, and models to predict outcomes. We will also focus on factors that affect and influence these 2 broad areas. So we'll first look at the health burden. First, a brief look at what IPF looks like globally, and I'm sure most persons are familiar with this. Most studies on epidemiology on IPF come from either the USA or European countries. And based on the literature, we see that there is a wide range of estimates, and this can either be because of the methods that were used to do those, to derive those estimates, or actual differences between countries. In Australia, however, while there is a lot known with respect to the clinical aspects of IPF, there is not known much on the distribution of IPF in the population. These studies usually require large data sets and lots of resources. So for our study, we tried to use data that was already readily available. And for that, we used the relationship between new cases, or what we normally call incidence, living cases or prevalence, and the survival and mortality. So the known parameters in our study were the mortality based on data from the Australian Bureau of Statistics. And sorry that I have to dwell on mortality, but our study used that method. Our study was based on this methodology. And we also used survival-based data, and this we got from the IPF registry. The unknown were the new cases annually and the number of persons actually living with IPF in Australia. And all of this was based on census data between the periods 1997 and 2015. So just a quick look at what persons enrolled in the IPF registry look like. On average, the average age was 71 years old. Most persons were male, and the majority of persons were not on antifibrotic medication. Now, one thing to note is the time frame of our study. So that's between 2012 and 2019. And antifibrotics started in Australia, started to be subsidized by the government somewhere towards the end of 2017. So our study period, most of our study period would entail a period where antifibrotics were not readily available in Australia. So that could explain why we have lots of persons recorded in our study with not on antifibrotic medication. So the first thing we looked at was a relative survival analysis. So our relative survival analysis, which looks at survival of persons with IPF compared to survival of persons in the general population of that same age, demonstrated that in the first year of diagnosis, there is an equal chance of survival in both groups. So that is persons with IPF and persons from the general population or persons without IPF. Subsequent to this, persons with IPF have a decreasingly lower chance compared to that of the general population for survival, and males have a lower chance of survival than females. Our results demonstrated that between 1997 and 2015, there were on average 10 new cases of IPF per 100,000 persons annually, and on average, 33 persons living with IPF per 100,000 persons annually. If we put this into context, this is approximately 11,000 persons living with IPF. There were a higher number of cases in males compared to females, more cases in persons 70 years and above, and the number of cases increased with increasing age. So while life expectancy has increased over the past few years in Australia, and persons are living longer, the chances of IPF have also increased as persons get older. So for example, you can see that in our table that the number of persons increased from 56 per 100,000 persons. If you look at the pointer, 56 per 100,000 persons at 70 to 79 to 400 in the 90 to 99 years old. So yes, people are living longer, but the chances of getting IPF are also increased. While we saw an increase in mortality and new cases between 1997 and 2015, we saw a decrease in mortality over the period 2017 and projected period to 2025. This may be due to antifibrotic treatment and also a slight decrease. We also saw a slight decrease in the new cases, which may be due to improved diagnostic criteria and technology for diagnosis. So more precise diagnoses are being made currently than in earlier years. We also wanted to understand the makeup of persons who are living with IPF. So we looked at the cases in the year 2015, which was the last year we had data for. Most persons were between the ages 70 to 89 years old. And beyond 5 years after diagnosis, the chances of survival decrease. But what we found quite interesting was that beyond, we also had persons who were alive beyond the period of 10 years after diagnosis. I will now hand over to my colleague who will provide some more insights into mortality, survival, and some more information on antifibrotic medication.
Okay, thanks, Ingrid. My PhD topic is survival and causes burden of IPF in Australia. So this figure shows global mortality trends of IPF based on previous studies. We can see from the graph that age standardized mortality is 4 to 6 per 100,000 population per year in Australia. And there is an increasing mortality trend of IPF worldwide after year 2000, which may be caused by aging population effects or several risk factors. For example, the bad air quality worldwide recently. This figure shows mean age at diagnosis and diagnostic delay between onset of symptoms and diagnosis for people with IPF over the past decades. The blue spot represents mean age at diagnosis, and the red spot represents diagnostic delay. Mean age at diagnosis is increasing over the past few decades, which means living longer is more likely to be diagnosed with IPF. Recently, mean time between onset of symptoms and diagnosis is around 20 months. We can reduce the diagnostic delay from 3 aspects. For people with IPF, visiting GP earlier when they get cough or shortness of breath. For clinicians, make clinical guidelines and multiple discipline team diagnosis more specific. For researchers, looking for diagnostic biomarkers for early diagnosis, such as serum biomarkers. This figure shows survival trends of IPF worldwide. We can see from the graph before year 2010, survival trends for IPF worldwide did not change, but there was an apparent increasing trend after year 2010, which may contribute to bad management of IPF and efficacy of antifibrotic treatment. Fig A is a primary analysis, and Fig B is a sensitivity analysis. We do a sensitivity analysis to further validate the consistency of our results. So before 2010, 3-year and 5-year overall survival rates were around 62% and 45% respectively. In the 2010s decade, 3-year and 5-year overall survival rates increased to 70% and 55% respectively. In order to prolong life expectancy for people with IPF, I investigate risk factor and protective factors in my following studies. There are 3 unmodifiable risk factors, including elderly population, being males, and genetic factors. There are also several modifiable risk factors, including smoking, air quality, exposure to mental dust, lung function, acute exacerbations, and comorbidities. Protective factors include antifibrotic treatment and lung transplantation. In fact, risk and protective risk factors are relative definitions. We can avoid the occurrence of risk factors. Then they become protective factors. For example, we found that smoking is a modifiable risk factor. Then we recommend people stopping tobacco use, which might be improve their life quality and survival time. There are many factors on the list, but I only focus on the air quality and antifibrotic treatment. First, I will investigate the association between ambient air pollutants and survival in Australia. A little background: in other countries, recent studies have suggested that increasing levels of air pollutants, small particulate matters, and nitrogen dioxide increased incidence rates, hospitalization, and mortality in IPF. In Australia, higher ambient air pollutants, especially for PM2.5, is associated with low baseline lung function in IPF. We also found ambient air pollutants are not associated with near-east distance to measure route, which means in Australia, the effects of air pollutants on IPF, which is not specific to the traffic-related emissions, which they might be from industry emissions and bushfires. There was a weak relationship between higher air pollutants and worse survival. In summary, there are limited effects of air quality in Australia, maybe because Australia has relatively good air quality compared to the countries that have been studied, compared with Italy and South Korea. The annual mean nitrogen dioxide is relatively smaller. And then I investigated the association between antifibrotic therapy and survival in Australia. In other countries, pifenidone is available for many years in Japan since 2008, but without randomized control trials or acceptable levels of evidence. In 2011, 2 antifibrotic medications were approved, having been shown to slow lung function decline in several RCTs in IPF. Antifibrotic medications have been approved in US in 2014 by FDA. Recently, a systematic review, including 8 RCTs and 18 cohort studies, reported antifibrotic treatment may improve survival in IPF. In Australia, we found antifibrotic medications have been approved in 2017. Prior to this, antifibrotic medications were available from RCTs, and several participants accessed the medication from overseas, such as India and Japan. In our study, we found people taking antifibrotic therapy also had improved survival compared to those without taking antifibrotic therapy. This figure shows the percent of people on medication use between 2012 and 2019 in Australia. These data are collected based on people-reported questionnaires in Australian IPF registry. We can see there is an increasing trend that more and more people are able to take antifibrotic treatment. That's all contents of my studies now. I will hand it over to Ingrid. She will introduce more information on health economics in IPF.
Thanks, Chang. So we'll now look briefly at the economic burden or the health economic aspects. So to understand the economic burden, let's first define what we mean by health economics. So health economics focuses on maximizing the population's health within the constraints of the resources that are available. There are 2 important components that are evaluated. First, value, which can be measured based on quality of life reflected by persons with IPF, clinical changes, life years gained, or mortality averted. Then there are costs, which can be direct or indirect. These components are then used to determine whether interventions are cost effective and the benefits compared to the cost. So for the purpose of this presentation, we will focus on quality of life. For persons with IPF, quality of life is measured using surveys, which many of you may be familiar with from the registry questionnaires. And there are some that are disease specific, and then there are generic ones. The generic ones have one advantage, is that they're useful because they allow comparisons across several disease areas. This slide demonstrates the average quality of life using the instruments mentioned previously in a subgroup of persons from the IPF registry. For the purpose of this presentation, we will focus on one of them, which is the Euroqual 5-dimension 5-level questionnaire, and we'll just refer to it as the EQ5D. So the EQ5D measures quality of life on a scale of 0 to 1, where 1 is the best quality of life. The average quality of life for our group of participants was 0.65. For the average Australian population person of this age range, the average quality of life is 0.87. So as you can see, it is quality of life in persons with IPF on average is lower than that of the general population. Quality of life for persons in our study the range was very wide, and it ranged from minus 0.57 to 1. We also compared our results to quality of life from other countries. So in this slide, we're comparing it to Germany, Netherlands, and the USA. So we noticed that that of Australia was slightly lower than the other countries that we looked at. Now, this may be due to cultural differences and also the composition of persons that participated in those surveys. So in these studies, when we took a closer look, persons actually had milder forms of the disease, whereas our study participants from the IPF registry had varied forms of the disease, so mild, moderate, and there were few persons with severe disease. So that could be the reason why the average quality of life we saw for the whole group was a little bit lower. Then we looked at the quality of life in IPF, in persons with IPF, and we compared it to other disease conditions. So persons with IPF had similar quality of life to persons with chronic obstructive pulmonary disease, or COPD as it's commonly called, persons with angina, and persons with uncomplicated stroke. But persons with IPF had a worse quality of life than uncomplicated bronchiectasis, persons with chronic kidney failure, and persons with uncomplicated lung cancer who are on treatment but have no side effects from their treatment. And persons with IPF had a better quality of life than persons who suffer from heart failure, liver cancer, and persons who have lung cancer but are on treatment and are suffering with side effects. We also looked at other factors than IPF that contribute to quality of life. And what we noticed was that persons with more than 2 other illnesses and worsening lung function decreased quality of life. The impact was worse with the comorbidities than seen with the lung function, but we also note that this is a generic instrument and it may not necessarily be very sensitive to disease-specific changes. So that's why we may not see such large decreases with the lung function. So moving on to costs, we spoke briefly earlier and said that costs can be either direct or indirect. And you can see on the slide some of the elements of costs that are included under each category. For the purpose of this presentation, we will focus on pharmaceutical costs and pharmaceutical costs specifically related to IPF. So as Hayden and Chang mentioned earlier, currently there are 2 antifibrotic medications, and these seem to delay, are proven to delay progression of the disease and in persons with mild to moderate disease. These 2 medications were subsidized by the Australian government and placed on the PBS scheme, the Pharmaceutical Benefit Scheme, for subsidization in 2017. So what we sought to do in this study was to assess the trends in utilization of those 2 medications since the beginning of their subsidization. So between the periods May 2017 to May 2020, which was the period that we studied, a total of approximately 44,000 prescriptions were processed. We noticed that there was a 72% increase from year 1 to year 2, and then a 26% increase between years 2 and 3. Total cost to the government of Australia for the period under study was approximately 131 million Australian dollars. More persons were on nintedanib than were on pirfenidone. Another observation we made was that the overall average monthly costs and prescriptions were highest in New South Wales, but costs and prescriptions were highest in the Australian Capital Territory when we looked at it based on the population size. What we attempted to do, we then used our prescription rates to estimate the number of persons living with IPF, making the assumption that each prescription was linked to one individual. We looked at 2019 as we assumed that since treatments began in 2017, uptake would have stabilized by 2019. Additionally, we did not have full year's data for 2020. So, excuse me, prevalence in 2019 based on prescription estimates was highest in the Australian Capital Territory, then South Australia and West Australia followed in second and third. When we looked at the data for all of the years, we saw a similar pattern. However, we should bear in mind that this is based on prescriptions, and this will relate to the access that persons have to specialist clinics and multidisciplinary teams. Additionally, treatment is limited to persons with mild to moderate disease. So our future work will take a deeper look into the geographical trends that we noticed in this study. So what will we be looking at next? Our future work will take a closer look at the trends and reasons for differences between geographic regions or states and territories in Australia. We also want to focus on prescribing practices and the frequency and types of adverse reactions to the treatments. Another important area of our research is the effect of comorbidities, as we realize that this has a big effect on survival and also on quality of life. And lastly, we want to have a look at acute exacerbations, which are most times responsible for hospitalizations, mainly looking at risks and protective factors in the context of the Australian population. Our health economics work will focus on costs related to comorbidities and acute exacerbations. And then we will also look at the cost effectiveness of treatments used to manage IPF, especially pirfenidone and nintedanib. Okay, so we will now open the floor to questions and comments on the presentation or on any other aspects related to health economics or epidemiology of IPF that you may have.
Thank you so much. Some great information there. I'm sure it was hard to condense it in for the hour's webinar. Now, does anyone have any questions that they'd like to send through to our speakers? There should be the Q&A chat box there that you can use to send any questions through. Okay, so I'll start with one here. Is there a reason that it's so difficult to track hospitalisations or diagnosis of IPF in Australia within the healthcare setting?
So in terms of tracking hospitalizations, I would say that not that it's difficult, but it might be more related to access to the data. So in terms of getting information on hospitalizations, what we have done through one of the studies that we're actually doing is we're looking at linked data. So that would give us information on both ED admissions and hospitalizations. But it's a very lengthy process to actually get approvals for all of that data. So it's not that the data is not available, it's just that it's difficult to access the data.
Okay. Thank you.
Can I just come in on that just briefly? Yes, just to reinforce what Ingrid was saying. Firstly, IT systems in hospitals are a sort of new arrival. There's relatively little spent early enough to get the data in a form that can be shared. That's one thing. Each state tends to do or develop systems separately, so they don't quite fit with each other. And then the way that privacy legislation has been written in Australia makes it very, very difficult to get access to this data, even when people have given their personal permission for you to access their data. The amount of work that Ingrid has had to do over about 18 months to get all the permissions has really been horrendous. I mean, we are probably going to write a paper just to show how difficult it is, because it is extremely difficult. I mean, hopefully that will change, but it's a bureaucratic nightmare.
Okay. Now I've got another one that has come through. So it's just jumped off the screen. From the figures that compare to overseas, is IPF more or less common in Australia than it is overseas?
So in terms of that, I can say yes and no. In terms of the data that we've seen for Australia, it's comparable to other countries, say for example, countries in Europe. But there's a large range of data that has been presented over the years. And what I think has influenced that, the varied number of estimates that we have, is the different methods that people have used to actually come up with those estimates. Additionally, clinical guidelines. So clinical guidelines have changed over the years. So in terms of how we classify IPF, and some of those studies have started from the 1980s, and some of that has changed. The clinical guidelines changed in 2000, then in 2005, in 2010. So that has changed the estimates over the past few years. But the numbers that we're currently seeing in Australia correspond to many countries in Europe, more recent studies in Europe. So I think, yes, I would say that it's on a similar level to many countries that we've seen in Europe.
Yeah, again, if I could say, there is one particular slide which Chang showed where the Australian data is right in the middle of the group. So I think we're pretty comparable to Western countries where the data is available. One of the problems with the data is that it tends to be average across the whole population, whereas I think Ingrid made the point very well that this is a disease essentially limited to people over the age of approximately 65, and particularly over the age of 70. So instead of being on average 5 per 100,000 of the population, which doesn't sound like very much, when you get over the age of 70, it's more like 0.3%. That's about 300 to 400 per 100,000. And people don't provide that data. They just provide this very averaged data. So it's a much bigger problem in the elderly population than you would guess from the average. So 0.3% is not enormous. If you look at COPD, chronic bronchitis, emphysema, those sorts of illnesses, then it's over 20% of the population over 70. And heart disease would be probably about 15%. So it's a relatively minor disease, but it's by no means insignificant in an elderly population.
Absolutely. Thank you. Now, Ingrid, I think you may have answered this in part in your last answer. Do you feel that this evidence from your studies has followed a similar course to previous estimates, so higher incidence in men and an older age, etc.?
Yes. So what has been seen in other studies around the world is, yes, the incidence and prevalence are higher in males. And I think Chang also mentioned that when he was looking at the risk and protective factors, that being male was actually one of the unmodifiable risk factors. And with increasing age, yes, the incidence and prevalence are higher in persons who are older than in younger age groups. And that has been seen in other studies around the world. So that isn't consistent with what has been seen globally.
Great, thank you.
If I could possibly also say that there are some differences in Australia. I mean, firstly, I think it's worth having specifically Australian data. But I mentioned in terms of risk factors, where in Australia, a family history, which means genetics, is much more important than smoking or environmental pollution. Whereas in other countries, it has tended to be the other way around. You know, good or bad. And the other part of the data which Chang showed, which is that there is some detectable effect from broad particulates in the air, but it is not related to road traffic pollution, which seems to be in Europe a much bigger issue. We didn't pick a signal for that, but there are very significant links to road traffic pollution in European studies. And again, there's a link to that in the papers that I've listed via Jamie.
Great, thank you. And so is there certain ways that this information may be used to help people with IPF going forward?
Definitely. So we have a lot of clinical information on treating persons with IPF. But if we don't know the extent of the disease in the population, it then affects how we allocate resources for managing the disease and also getting treatments that are useful in prolonging survival in persons who are living with IPF. So I think quantifying how many persons is important, especially for policymakers and for the government in terms of subsidizing the medications, because they're quite costly. So I think quantifying what exactly is happening in the population is quite important. So I think it does help persons with IPF in terms of resources being allocated to persons who actually need it.
Thank you.
And if I could again endorse that, in clinical trials, it's quite difficult to pick up some signals. So if you look at the IPF antifibrotic trials, they show quite good signals for reduction in the rate of loss of lung function over a couple of years, but don't pick up much in terms of survival. What we've shown from a population perspective, and this is why population perspectives are very valuable, is that the mortality rates decrease by about at least 30% with the drugs we've got. And these are the first drugs. And as I say, on the basis of our understanding, these drugs endorse that we are getting a better understanding. And it gives us a very good feel about what the next 10 years will bring in terms of drugs that can affect that system. If we weren't picking up these strong signals from large community studies, it would be extremely disappointing. But actually, it's very encouraging.
That's great, thank you. So we might have to leave this one as the last question. Was there, in your studies, was there much to do with PF or IPF in this instance, and possible workplace exposure or asbestos exposure?
We didn't focus, while we looked at general occupational exposure, while we looked at occupational exposure in general, we didn't actually focus on any specific occupational exposure, for example, silicosis or asbestosis, etc. So we have not looked at that, but that could be some of the future work that we can look at.
Okay.
Yeah, again, if I could add, we did this is the broad we, the CRE community, which has grown over the last decade. With Mike Abramson in Melbourne, I was involved in a large case control trial, case control analysis of occupations and other risk factors. And there was a small signal in terms of incidence, that's the number of people getting illness, if they worked in a non-specifically dusty environment. There was a weaker signal, but there was a signal for people who'd worked with asbestos. So there probably is a crossover between frank asbestosis, which is fibrotic lung disease related specifically to asbestos exposure, and what we are picking up as this idiopathic form. So some people with IPF may have, in reality, asbestosis, but it's a very small overlap. Our diagnostic criteria are really quite sound. Though I think the way people are now looking at fibrotic lung disease is really to try and put them all together as progressive fibrosis rather than try to divide them up. I mean, it is likely that the underlying core pathology, the actual driving mechanisms, will end up being pretty similar between asbestosis, IPF, and the diseases related to autoimmune diseases like rheumatoid arthritis and systemic sclerosis and lupus and so on. They all have clinical differences, but it is likely that the underlying progressive lung fibrosis will have more in common, and particularly in terms of what drugs will work, than not. I don't know if that's helpful or not.
Okay, thank you very much. Now, so I've got two more questions and then we'll have to wrap it up there. Within your research, was there any way of knowing how long the disease process has been developing up to the point of diagnosis?
That's a very interesting question and something that we have been looking at for a period of time, I think for the past 3 years since we started. So it's quite difficult to actually define when the disease actually started. So we have different proxies for disease onset. So one of what we use is cough. And clinically, we would look at HRCT and other forms that the physicians we use. Now, cough is a tricky proxy because there's several other things that can induce cough. So, for example, if the participant or patient was a smoker before, so that is a very tricky proxy. So we've been working with the registry in trying to define what we're using as our point of diagnosis, but that has been very difficult, especially in terms of when persons joined the registry. So after 2017, it was mainly done through multidisciplinary clinics, but prior to 2017, it was done through persons being referred to the registry. So in terms of the point of diagnosis, it's very, it's a difficult country that we've been dealing with for a while, but we've tried to accommodate in all of our analyses, different points of diagnosis and how it affects the results of our analyses. So we conduct a sensitivity analysis with all of the different points that I've mentioned before. So whether looking at cough, or whether it's the HRCT from the physician or the multidisciplinary team. So we're incorporating all of the different points of diagnosis that could be possible in our analyses and see how it varies the results.
But we think it's about 20 months,
yes,
at least in terms of registry, from the first, the likely first time the person was aware enough to go and see a doctor about it, to actually getting into our registry.
Yes, between 15 and 20 months.
Okay, sounds like something we'll hear more about in future research as well. All right, so are there any figures on the incidence of familial IPF in the total population of IPF patients?
We did not specifically look at that, but there is another researcher at Menzies who is doing some more work on that. And I think she's working with the IPF registry in terms of recruiting persons and looking at familial IPF.
Okay.
Yes, we're doing genetics of familial IPF, and it's very difficult because what you find is if you do these high resolution CT scans on first-degree relatives, you will pick up very mild disease in not an insignificant number. In the case control trial, we showed that the relative risk was 12-fold. So it is likely that a goodly percentage of IPF will end up being familial. Now, it's a guess, but I'd say about a third probably. But we will know a lot more about that over the next 3 to 4 years.
Great, thank you. We'll wrap up the Q&A session there. Thank you to our presenters for your presentations today and a very informative Q&A session there as well. We really appreciate you taking the time to share your findings with us. And it's a topic area that we've had great interest in, so it'll be a really valuable resource and really highlights the wonderful work that you do as well. So thank you for sharing. Thank you. Before we do wrap up, I did just want to take a moment to direct you to some of the resources that the Lung Foundation have for people living with PF and IPF. So these include more of the webinars in the pulmonary fibrosis series, the online booklets, and a suite of IPF fact sheets as well. So these can be accessed on our website or through our information and support centre, and that number's the number you see on the screen there. It's 1800 654 301. The Lung Foundation have some amazing peer support options available as well, if you haven't heard of them. So there's the Peer Connect service, which is a telephone-based service specifically designed to connect people living with PF and IPF right across Australia, as well as 2 online peer support groups. So there's IPUF, and this is for people living with PF and IPF, and We Belong Together. So this is for carers and loved ones of those living with any lung condition. So if you are interested in joining or learning more about the peer support options, you can visit the peer support section on our website or contact the Information and Support Centre as well. You will see on the flyers there, they do have the QR code, so you can scan them on your screen, and this would take you straight to an EOI form, and we'd get in contact from there. So thank you again so much to our speakers and everyone that's joined us today. We really hope, and I'm sure that everyone was able to gain something from today's webinar. So with that, I will say goodbye and close the session for today. Thank you, everyone.